My name is Avni Bavishi, and I'm a resident at Northwestern. Today I want to present a case titled Flash Pulmonary Edema, Not Always a No-Brainer. So let's start with the case. A 67-year-old female with a past medical history of well-controlled hypertension and spontaneous coronary artery dissection has crushing chest pain that wakes her from sleep, and she drives to the emergency room. Her initial EKG is shown. This EKG is concerning for ST segment elevations in the inferior leads, 2, 3, and AVF. This is concerning enough that a STEMI is called, and the patient is immediately taken to the cath lab for an urgent catheterization. In the cath lab, she gets a coronary angiogram, which shows angiographically normal vessels. There are no obstructive lesions and no evidence of spontaneous coronary artery dissection. She also gets an LV angiogram, which shows some mild apical hypokinesis. After the procedure, she's taken to the cardiac ICU, where she's hemodynamically stable. She is having persistent chest pain and is newly feeling short of breath, requiring 2 liters nasal cannula with an oxygen saturation of 99%. Her exam is largely unremarkable. She's neurologically intact and able to speak in full sentences, but has some crackles at her bilateral bases. The chest x-ray shows some mild pulmonary edema and diuretics are ordered. Half an hour later, there's an urgent page sent asking that the team comes to the bedside. Her vitals are dramatically worse than what they were 30 minutes prior. She is now tachycardic, hypertensive to the 190s over 90s, her respiratory rate's in the 30s, and she's requiring 100% face mask to maintain an oxygen saturation of 96%. Even worse is her exam. She's difficult to arouse, her speech is unintelligible, and her extremities are cold. At this point, we're extremely concerned that she is not oxygenating well enough, and she also is unable to protect her airway, so anesthesia is called for intubation. We also start a nitroglycerin drip, concerned that hypertensive flash pulmonary edema is driving this new oxygen requirement. When anesthesia arrives, they start bag masking the patient, and as they do that, pink frothy fluid starts to emerge from her mouth and her eyes due to the positive pressure. After a successful intubation, a chest x-ray is obtained, which shows severe pulmonary edema in both lungs. So what is going on? We started this case with a patient with chest pain and ST elevations, and now have a patient with severe pulmonary edema who is intubated. So why did she have the ST elevations and chest pain? Well, we ruled out an ST elevation MI, as well as a spontaneous coronary artery dissection. Pericarditis is less likely given that the ST elevations were not diffuse and were rather in a vascular territory. Coronary vasospasm is also less likely because the patient had chest pain that persisted from the time she woke up to and through the cath all the way into the ICU. Coronary vasospasm usually does not last that long. So we're left with Takotsubo's cardiomyopathy, a real consideration especially given the finding of LV hypokinesis at the apical segment that was seen on the LV angiogram. Okay, but then why did she have flash pulmonary edema? So we'll get there in just a few minutes. Let's talk about what we did in the next few hours. The patient had a CT-PE, which showed no evidence of acute pulmonary embolism, also had an echo, which showed some septal and inferior apical wall hypokinesis, as well as a mildly reduced ejection fraction of 48%. This is consistent with a diagnosis of Takotsubo's cardiomyopathy. The patient's oxygen requirements have improved. She's now requiring an FiO2 of 40% and a PEEP of 10. This has happened without a brisk diuresis. In fact, while we tried to diurese the patient, she did not have significant urine output, and her blood pressure is also normalized pretty rapidly and has been off the nitroglycerin drip for quite some time. The day progresses and it's time for shift change. Right before shift change, the nurses do a routine sedation wean and neuro check, at which time they note that the patient is following commands only on her right side. So a stroke code is called, and the patient is taken for emergent brain imaging. This is a slice of the MRI brain that was done, which shows a pretty dramatic finding. There's an extensive area of infarction of pretty much the entire hemicerebellum. When we get the imaging results, it shows that there was cerebellar infarction, as well as multiple embolic strokes throughout the cerebellum. She had periischemic hemorrhage, as well as cerebellar edema. So let's talk about this case. There's a lot going on here. What happened first? What came first, the chicken or the egg? The pulmonary edema, the chest pain, the ST elevations, and the stroke all have to be tied together somehow into a neat package. This was a patient that came in neurologically intact on arrival. She didn't have a ton of risk factors for stroke other than her well-controlled hypertension. We believe that the stroke was a consequence of her coronary angiogram. Embolic strokes are a known complication of caths due to dislodgement of plaque. In fact, one study found that if you do an MRI before and then after the left heart cath, 8% of patients had emboli. However, they were mostly asymptomatic. Patients who actually had stroke or TIA were much rarer, about 0.5% of diagnostic left heart caths. So why did she have the ST elevations and chest pain in the first place? Like we talked about, this is most likely due to a Takotsubo's cardiomyopathy, and in fact, she had a repeat echo the next day, which showed resolution of the wall motion abnormalities and normalization of the ejection fraction, which is consistent with these transient abnormalities that occur with Takotsubo's cardiomyopathy. Now, it's true, we did not have a known physical or emotional trigger for this patient to develop Takotsubo's, but that does not exclude the diagnosis. And then why did she have flash pulmonary edema? We initially treated it as hypertensive flash pulmonary edema. However, there are other causes, such as acute myocardial infarction, acute decompensated heart failure, acute valvular regurgitation, or even bilateral renal artery stenosis. We believe that the true cause was actually neurogenic pulmonary edema, secondary to her strokes. Before we talk about that, you may be wondering why we don't blame Takotsubo's cardiomyopathy for this flash pulmonary edema. Because of the rapidity of the onset of pulmonary edema and the offset, it seems less likely that this was because of an acute decompensated heart failure. She did not really have a lot of extra volume that needed to be diuresed off. In fact, she just had a rapid onset pulmonary edema that resolved just as quickly. This is consistent with neurogenic pulmonary edema, which can be precipitated by pretty much any sort of central nervous system injury. Hemorrhagic or ischemic strokes, traumatic brain injury, status epilepticus, intracranial edema have all been shown to cause neurogenic pulmonary edema. The mechanism is thought to be due to a rapid catecholamine surge that causes an increase in systemic and pulmonary vascular resistance, causing rapid fluid extravasation from the pulmonary vasculature. This would also explain our patient's sudden rise and fall in blood pressure. So here's the proposed timeline. The patient had a new Takotsubo's cardiomyopathy, which caused her chest pain and the ST elevations. She then was rushed to the coronary cath lab for an angiogram, which unfortunately caused a cerebellar stroke. The patient then had neurogenic pulmonary edema as a consequence of her strokes. So there are a lot of lessons to be learned from this case. First of all, typically when we see acute pulmonary edema, we think about cardiovascular afterload reduction. But in certain cases, the true etiology could be totally independent of the cardiovascular system. And sudden onset pulmonary edema without an obvious trigger should raise concern for neurogenic pulmonary edema in the proper clinical setting. Second, stroke is a real complication of coronary cath, and these risks should be discussed with the patient when obtaining consent. And finally, in the ICU setting, don't forget about sedation holidays and neuro checks. These are critical for catching neurodeficits early in these patients. Thank you to the Northwestern Internal Medicine Residency Program for this opportunity, Dr. Didwania for being a fantastic program director, Graham and Arushi, some of our chiefs for looking over my presentation, and ACP for putting together this wonderful virtual conference.